go on to what we had planned for today. All right. Well, yep. Okay. Yeah, it's perfect. Okay, so we are members, and here are members that started from the very beginning: Rosa Solórzano, Ergin Falsman, Andrea Toomey, and then Gaby Plasencia, Paulina Ruiz, who is our project manager, but also new people like Natalie Sanchez. I'm trying to see who else is in the room right now, who I might have not mentioned, who is new to our team. So Project FIEL-NC aims to exactly what it stands for: fostering insurance enrollment among Latinos in North Carolina. And it's a collaboration of Duke Family Medicine and Community Health together with the Duke School of Nursing, Duke Margolis Center for Health Policy. And when we started with Dr. Gabriela Maradiaga Panayotti, also the Department of Pediatrics. And we are generously funded by the KB Reynolds Charitable Trust, they had funded us for the 2 years of the initial that we're going to present today, and then we are funded again for another 2 years. So we're very, very excited. Thank you. Next one. So we'll share some background and context and some of the interventions that we did, some policy recommendations, and some future directions. Next. And why did we, as a team, decided to really get together on this topic? Well, the Comunidad Latina represents 11% of North Carolinians. There's 1.2 million counted people. I will offer that it's probably more than we know. And it also represents 1/3 of all North Carolinians without insurance, which is one of the highest uninsured rates in the country. Next slide, Paulina. And it's even more than that, because if you look at adults ages 19 to 64 years of age, 44%, almost half of Latinos had been uninsured, in comparison to 16% of individuals who are self-reporting to be Black and 11% of white people. So it is a concern in regards to access to healthcare, and the disparity, and what are the reasons for it. Next slide. So we aim to increase the enrollment of currently uninsured but eligible members of the North Carolina community who identify as Hispanic, Latino, or Latinx in Affordable Care Act, health plans, or Medicaid. And it doesn't escape to me that this moment, many of us are going to ask ourselves questions. Who is going to be eligible? In 1.5 months may be very different from who was eligible until the new executive actions. Although we do know that the state of North Carolina is one of the states who is suing the federal government in regards to this. Next slide. So how did we get started? We started earlier in November of 2022. So this is even 1 year before there was an expansion of Medicaid, with community listening sessions. And at that time, some of the takeaways were that enrolling in insurance is complex and tedious. Resources were unknown, they were uncoordinated. People had difficulty finding their way through resources. There was unfamiliarity. People didn't know what were the eligibility criteria, who was eligible, and also navigating the systems. That there were desire for alternative forms, different ways needed. There was a need for different communications, different resources, and specifically there were a lot of fear related to immigration repercussions, right? That the fear of becoming a public charge was really significant for a lot of people. And so we started talking about potential solutions, linking interventions and partnerships with essential or high traffic services like schools, churches, consular offices, develop materials to streamline and consolidate resources and information, and address what were the questions that people have, what were the misconceptions, what were the ideas that made people doubt about getting insurance even. Then considering in-person resources or alternatives for them. Our comunidad, la comunidad latina usa WhatsApp a lot. That's a big way of communicating with each other. And then also another solution was to identify policy action steps to overcome those barriers. Next slide. So our project FIEL-NC started or developed with this, what we call pillars. And at the same time, these pillars mesh with each other. They're not silo systems. We created teams, but there was always communication within these three teams. There was a navigation and communication pillar, an education and training pillar, and a research and policy. And under navigation and communication, we started with developing a contact list of strategic partners. We started doing some stakeholder engagements with community-based organizations and the Latino Community Credit Union. We started doing focus groups with community health workers, recruited community health workers and partner organizations for educational opportunities, and then disseminated information through different ways, handouts, flyers, etc. As we were doing navigation, and again, it's like nothing is one thing exactly related on time, but the education and training team started doing a library of resources. What was available? What were resources? Started developing educational materials for the community health workers and community members at the Latino Credit Union. We'll speak a little bit more about the Latino Credit Union, but some of you may not be aware, they do financial education classes. And so we started looking at how did they educate the public about financial education so that we could use their way of teaching in our way of teaching about insurance, much as financial education was being done. We started leading trainings for community health workers, community-based organizations, and community members, and evaluated outcomes through surveys and interviews of community health workers. And the research and policy team, again, started early doing a descriptive analysis of publicly available census data to select which were the counties in which we will have best gain, right? Where should we concentrate on efforts? We started looking at the EPIS framework literature review, and Gabriela Plasencia is going to talk a little bit more about that. We started doing policy interviews with key informants and community leaders, and then worked on analyzing the FIEL-NC qualitative research initiatives. And then there is this dissemination phase through manuscripts, posters, articles that have been already published, and others that are in publication. Next. So this is just one graph that kind of shows a little bit of what the community health worker health insurance training program looks like. So we could actually make graphs of a lot of different things that we're doing, but we started with focus groups. We started with going to the Latino Community Credit Union and developing materials and recruitment of community health workers. Sorry, we started with literature search, reviewing of the public data. Then we went to GIS mapping and review of what were the community infrastructure to then go to the focus groups and developing the material. And then once the material was developed, we did pre-surveys to try to understand where were our community health workers from around the state in the key counties that we engage with and community-based organizations that we engage with. We then did the survey first to understand what was the understanding about insurance, did the training of community health workers, and then did post-surveys in anonymous satisfaction surveys. Then we did supervised hours where we, after they had done and understood all their material, they did practicum hours, and then they went on to do training as trained trainers and work then in community education. Next slide. Gabby? Or is it?
It's me, sorry. I was trying to find my mute button. Hola, ¿me escuchan? Can everybody hear me?
Sí.
Wonderful. So as Viviana was explaining, one of the first things we did was to do community health worker focus groups. We wanted to hear from community health workers with direct experience with la comunidad Latina, what they have heard about people's experience enrolling in insurance, how, what were some of the barriers, what are some of the things that helped, and what are some of the potential challenges that we can try to address with some of the resources we were creating, looking for, and, how can community health workers be a part of this solution? And so these are some of the things that we heard from the community health workers. Having people talk about their personal community experiences was very helpful. Discussing what were some of the concerns and some of the actual barriers that people were facing. And then you can see in smaller font the cost of enrollment. People were afraid, like, if I get insurance, how much is it going to cost? Is it just cheaper if I don't get insurance and just go to the emergency room when I need care? Having things like manuals available for community health workers to help train community members and talk to community members about these topics, which for English speaking populations are difficult to understand. Imagine for people who speak Spanish, who aren't from the United States. Our insurance system is very complicated. So these are some of the things we heard from the community health workers. Next slide. We analyzed these discussions with the community health workers and found 8 key themes. And you can see here the themes were organized into barriers and solutions. So number 1, language, of course, having resources in the right language is both a barrier and something that we can try to create a solution for, both with materials themselves, but also having community health workers that can help discuss this information. Lack of understandable materials, again, trying to make the materials easier for people to understand, not just based on language, but also education level, and having things like vocabulary glossaries, etc. Personal community experiences, as you saw, that was something that was most important, right? If someone's coming to this country, doesn't understand the insurance system, and is also afraid of being reported, to ICE, etc., having people talk about what their experience is or has been, what information is going to get reported or used for, who has access to that information is really important. And so we created resources that focused on personal community experiences with insurance and enrollment for insurance. So focused on community stories as a way of educating. And then also having cultural trainings. And again, of course, community health workers were at the center of all of this. Trust and value proposition, again, trusting that the information is being used for what people say it's going to be used for, and what is the value of insurance. This is something that was very important. Imagine, if you're afraid of the cost of insurance and you don't typically go to the doctor very often, is it worth getting insurance at all? How is insurance helpful? And so having those community stories helped with that. Trustworthiness of the system, community power and knowledge. So focusing on the power of the Comunidad Latina and how coming together can help the entire community was very important. And prioritizing, trying to find funding for, initiatives focused on la Comunidad Latina, et cetera, and education initiatives. Cultural humility, of course, and relationship building. Of course, we can't do this alone, especially not across the entire state. And so how do we build relationships with other community-based organizations, with the state, government, et cetera, to help make this something that is more sustainable? And, many people are focusing on this in the entire state, not just us. And so how do we put our resources together and make this more effective so that we can reach the people who need it most? And so here were 3 main urgent and addressable barriers discussed: community power and knowledge. You can see here the quote. They think it's basically that sometimes because you're Latino, you don't have the opportunity to have insurance. Language, moms don't even take their children to the pediatrician because they say, can you make an appointment for me if there's a doctor who speaks Spanish or something? Because even to make appointments, we don't have the option to do it in Spanish. And lack of understandable materials. No, they are not clear on the documents that are needed. Lines are delayed, the family gets tired and does not consult. So you can see here some of the stories that we heard from the community health workers about some of the issues people face during enrollment or accessing healthcare services. So this is what we call the EPIS framework. So we used, if you're familiar with research, we use the dissemination implementation framework called EPIS, which is based on exploration, preparation, implementation, and sustainment. So you can see that kind of in the arrows going around the outside of the circle. And basically it's a way of analyzing a intervention or a program to see what aspects of it are going well, what aspects of it need to be improved. And then you can look at what are the factors contributing to that intervention or program going well or not. So those factors include outer context, what is happening outside of the organization or program, things like politics, things, cultural things, etc. So that's the outer context. The inner context is what is happening within the organization or within the program itself that helps or doesn't help the program do well. So things like leadership, organizational characteristics, service environment, etc. And then there's bridging factors. What are the things that connect the outside or outer context to the inner context? And so, are there any sustainable relationships or partnerships between state government, local government, federal government, and community-based organizations? How are those things sustained or not? And then innovation factors. What are things that are new that need to be studied a little bit more, or that people have tried to improve whatever program, intervention, goal. So we did a literature review using this framework to figure out what is out there, what have people done to improve outreach and enrollment of Latino populations that are eligible for insurance but not actually enrolled. Next slide. And what we found from that literature review was that the majority of, peer-reviewed articles, policy articles talked about, either the outer context, the policy, or the inner context, the organizational factors. Very few talked about bridging factors or talked about how there were no bridging factors between the two. So we wanted to look a step further and talk directly to policymakers, to payers, right, Blue Cross Blue Shield, and others, and then talk to also community-based organizations to see what are some of those bridging factors or other solutions that have been attempted either at the, state, federal government, or at the organizational level to conduct this outreach to people that are eligible but not enrolled. How do people know who is eligible but not enrolled, and what has been effective or not effective for this population? So we interviewed 20 people, 7 community leaders, and 13 key informants, policymakers, payers, et cetera, and then are in the process of doing thematic analysis of those interview transcripts now. Next slide. And then in addition to that, we wanted to make sure that with the limited resources we had, we were able to reach the counties that needed it most, right? What were the counties that had the highest percentage of people eligible but not enrolled in insurance? The problem with that, as we found out from those interviews, is that there is no data source that looks at specifically who is eligible but not enrolled, which is crazy to think about because every state has Medicaid programs, ACA, in the entire country, and there is no data available, publicly available, or even, not publicly available that we've been able to find, that looks at who is eligible but not enrolled. And so the issue with that is that then they have no information to develop tailored outreach, right? Is that population mostly white, Latino, Black, et cetera? How do we do the outreach? Why is it that people aren't enrolling, et cetera? And so what we did, since we didn't have that information, was look at census data. And so using the census data, we looked at the percentage Latino per county, we looked at the percentage under the federal poverty level, and we looked at the percentage of people that were uninsured. So that gave us an estimate of what were the counties with the highest likelihood of having a high proportion of people that were eligible but not enrolled. And we looked at both percentage and actual number because, as you can imagine, in for example, rural county that has just a smaller number of people total, the percentage of Latinos might be small, but the number might be big, and vice versa. I may have said that backwards. In urban counties, the percentage might be small, but the number might be big. And so we looked at both. And I think Andrea Tumi's on the call, which was the mastermind behind all of the Excel sheets and analysis for this. But with that, we were able to see the counties across all of North Carolina, out of the 100, how many of them had a high proportion or high likelihood of having a high proportion of people that were eligible but not insured. Unfortunately, it was a high number of counties that met the criteria. And in general, we're able to look at or prioritize 17 counties total, and tried to make sure that we had a good mix of rural and urban counties. And then looked at across those counties, how many of those had community health worker organizations or organizations that employed community health workers in their area, and which counties had LCCU branches. So all of that information together was how we chose our priority counties for this.
Okay, thanks, Gabby. So I'll take it over from here and talk about our community health worker training program. And we have 3 aims for this component of our project. One was to partner with community-based organizations with Spanish-speaking community health workers that serve Latino communities in North Carolina. So the map on the previous slide helped us to determine which areas to concentrate our recruitment for these partnerships, and to see which organizations might be in the correct counties or the prime counties for us to partner with. The next aim was to provide culturally and linguistically appropriate training for community health workers around health insurance topics. And Viviana talked a little bit about this, but the focus groups helped us to determine the kinds of materials that we developed for our community health workers, and then also the Latino Community Credit Union financial literacy classes also help to inspire the types of format of training that we provided. So along the right, you can see some examples of some activity sheets that we had for our community health workers. These are examples of a health insurance and immigration worksheet, and one for the ACA. And you can see on the sheets we have some QR codes, and these are resources for them to practice with, so that when they go out into their communities, they know how to use, for example, eligibility for health insurance for immigrant communities in North Carolina, the resource from the North Carolina Justice Center. So this was for practice during the training. And then our third aim was to track community health worker-led education and engagement efforts among their communities related to health insurance. And I'll get into a little more detail across the next couple slides. Just hit next.
Sorry, Paulina, while you're doing this, I wanted to hold the moment to recognize that Irene Felsman, and then this is the work of bringing students to this. Rosa Solórzano, Irene Felsman, leading the education group, and especially having had the opportunity to work with Jacob Pinto, who before coming into the School of Nursing had been an insurance person. He used to work and advise people on insurance, really helped us all to learn a lot more to be able to create this material. I don't know, Irene, if you want to say something about this, but I think it's an important I think we can't say enough of how much having a person who had multiple years of expertise with insurance plans had for this team to really be able to develop really excellent educational material.
Yes, I'll second that. We were just really fortunate that he was willing and able to join us. And I'll also call out Natalie Sanchez, who's here today, who's also she's a medical student who's worked with Jacob recently. They are experts at Canva and all kinds of other technology that makes my head spin. So it's been a real group effort to pull all these materials together. So thanks for acknowledging that, Viviana.
Yeah.
Sorry,
right. Paulina, go on.
No, it's okay. I'll shout out Jacob. He's right here on the screen. I don't know if he's in the room today, but okay, so back to our training, just a little more information about the format. It was 8 hours in total, virtually done in 2 sessions in September and October of 2023, covering training topics health insurance basics, what is health insurance, why it's important, the system of health insurance in the United States in comparison to some countries of origin for Latinos in North Carolina, immigration and health insurance topics, addressing key myths and misconceptions and trying to connect them to high value information and resources, health insurance options, ACA, Medicaid, Medicare, employer-based, and eligibility criteria and resources there, resource coordination, how to get connected to the Navigator Consortium, to the local DSS office, to SHIP, how to find resources about public charge. And then finally, utilization basics as a newer topic that we added, but just in our conversations with the community health workers and as we were going through the training, seeing the great need for also information about how to use the health insurance once it's acquired. Okay. And here is another map along the bottom. You can see the organizations that we partnered with for our community health worker training program. In total, we had 81 community health workers participate in our 2023-2024 program. The stars are the 17 priority counties that Gabby presented, and the shades of purple indicate the concentration of our community health workers. So the darker shades of purple are where we had a greater number of community health workers indicate that they serve Latino communities in that particular county. Okay, and then our pre-post training assessment. This is just a component of that pre-post training assessment, but we had a series of statements and then they were asked to agree, disagree, or indicate that they were unsure. These are all in Spanish, but I can share a couple in English as well. I know where to find resources about Medicare. I know how to help someone determine their eligibility for a health insurance based on their immigration status. I know how to explain what Medicaid is. I can explain why having a health insurance is important. So right here on the left, you can see pre-training and the variety of agree, unsure, and disagree. And then post-training, you can see the shift towards agreeing with these statements, demonstrating the effectiveness of our training in getting the community health workers to feel more confident and more capable to help their community with these health insurance topics. And then after our training, they had funded hours to take what they had learned and to apply it to their work in their communities, communicating the value of health insurance, addressing common misconceptions, sharing general eligibility information about general insurance options, and connecting to resources. So not necessarily training them to be health insurance navigators, but helping with all of these different tasks that could help someone get connected to a navigator, to help them feel like they have the information to make an informed decision about their health insurance, and to actually get enrolled if that's available to them. And here are just a few more pictures of our community health workers doing the great work with their communities. And I will click next here. And in total, 8,190 community members were reached through our FIEL-NC community health workers as shared through their weekly engagement surveys. And these next couple of slides, I will breeze through a little more quickly for the sake of time. Happy to revisit these if there are particular questions. But within the weekly surveys, we also asked them in the last week, what are topics that you discussed with community members? And we have them in different buckets. So this is the general topic bucket. And here, most commonly discussing basic topics of health insurance. What is health insurance? Why it's important? Basic terminology, followed by options and eligibility for health insurance in general. Within the topic area of Medicaid, most common topic discussed, eligibility for Medicaid, followed by a description of Medicaid, what it is, what are the benefits in general. Medicare, most commonly discussed, a description of Medicare, what it is and the benefits in general, followed by eligibility. For the Affordable Care Act, most commonly discussed description of ACA, what is the ACA and the benefits in general, followed by eligibility as well. And then what types of resources did you share? So most commonly sharing resources about Medicaid, followed by ACA, then Medicare, then immigration, legal, and advocacy resources. And we also asked them to indicate the number of community health workers that they assisted with certain list of tasks related to health insurance. And I'll go through all of these. Most commonly, helping to determine eligibility for health insurance based on immigration status, followed by connecting with a local DSS office. And then we had estimating a cost for an ACA plan using, at the time we were using Health Sherpa. Next, connecting with a navigator for health insurance, so Navigator Consortium. And then lastly, connecting with a Medicare navigator through SHIP. And then these are some comments from our community health workers, free text comments. These have been translated to English. I'll give you all a moment to read and just highlight a few here. There are definitely many with immigration statuses who don't know that they can apply for health insurance. And then here's another one of how they helped a person get connected. Some who preferred to complete paper applications but did not have access to printers or transportation to go to DSS. I gave them the phone number and we did a 3-way call to connect them and request assistance in Spanish, and they were able to complete the application. And also being able to clear up doubts and misconceptions, telling them about the ACA. There were lots of folks who didn't even know about the existence of the ACA. The strategies in which they communicate the value of health insurance, connecting them to a scenario of if they broke their foot playing soccer. So the ways that they were able to connect with the community culturally. And then these are some more quotes just talking about the community health workers' own experience in doing this work with their communities. Again, these have been translated to English. I believe this change will benefit many children and adolescents in Durham. Families are showing great interest in spreading the word. We have felt how the Latino community appreciates having people from their own community explain these benefits to them. This week, we also helped a young woman with a student visa who was able to apply. And I'll just pause there. Viviana, is there anything else you wanted to add about the community health workers' role in connecting the community to health insurance?
No, I think it doesn't need to be stated to this group how important community health workers are in connecting with communities and in really getting the information to everyone in safe places, and how great it was also for us to see how much the community health workers were learning a topic that is so difficult to navigate. Also, it would be important to say these are not community health workers who are navigators or part of the Navigator Consortium who are trained to help people navigate. These were community health workers that are working with communities at large who are trying to understand insurance, and this has really been helpful for a lot of people.
Okay, and then what are we doing now? So we have updated our community health worker training program, and this program is ongoing. So we'll definitely loop back once we have some more information and some outcome information from that program. But we modified our training to be self-paced, so 6 hours of pre-recorded modules. And on the right, you can see a graphic here of an example from our toolkit that we are developing so that other organizations and individuals can take these training modules and our unit activities and self-guide through the training. But the different components include a video presentation that we have on a YouTube, and then an accompanying unit activity that they can print and complete. And then we go through the answers in the video, and then accessible community resources that they can also have during the outreach with the community. So we have our self-paced training that is approximately 6 hours to complete. We have similarly our surveys pre-training. We have unit surveys, since these are now videos, to see what information was still left unclear, post-training survey, and a satisfaction survey. And what we did for our 2024-2025 program is after they completed this self-training, we had shorter live virtual classes to go through the questions that were still lingering and do some more practice together. And this was all done before they then did their CHW outreach work, their funded hours. And then they're currently doing those hours of community engagement and completing their weekly community outreach surveys. Okay,
There's
so that is.
Sorry, Paulina, there's a message that came through the chat directly to me that asked about how do we define community health workers? Are they social workers or nurses? No, community health workers often are lay community members who have some of them taken the community health worker certificate, what we call promotores de salud. Some of them might have been nurses or members of clinical staff in their countries of origin, but not practicing as nurses, physicians, or social workers within the United States. But they started as promotores de salud, health promoters, and many of them have gone on to take the community health worker certificates that are being offered throughout the network of community colleges in North Carolina. But no, they don't need to have a community health worker certificate to be educating the community about health issues. In answering questions and bringing them to our attention.
Viviana. Okay, I will pass it over to you to present about the LCC work.
So we partnered with the Cooperativa Latina Credit Union because we were interested in what they were doing in regards to financial literacy with health, to pair both financial literacy to health insurance literacy. And we saw there were many parallels in how you can speak about insurance to understand how having insurance is an investment. In some ways, like saving money is an investment towards your future. Having health insurance is an investment towards your health. So we started attending their classes and looking at how they were training the community in regards to financial literacy, to develop culturally and linguistically appropriate these modules to really reach to the community. I have to say that as I attended this myself, I started realizing how much I needed to learn in regards to financial literacy. And if anybody is listening to this, do contact your branch of the Latino Community Credit Union and see if you can attend their classes, because they're just amazing to understanding, how to navigate finances in the U.S. Next step. We started with modules from the very basic to CARES, what is health insurance, what is a network, who is eligible, and then going on to next slide, more detailed examples, right? Different history, different stories that can illustrate, who is eligible, both for mothers. There was a question in the chat asking about mothers and babies. Yes, we had examples of a mom who is pregnant and her family is growing, and what are the steps that are necessary to go, to older people. Like in the case here, you're looking at Jose Fabio, who is about to retire, and trying to understand what is Medicare, what are the differences. And then how people who might have actually gotten their insurance through the ACA, the Affordable Care Act, were able to save some money through going through the ACA to get their insurance. So we really went to looking at the material. And again, Irene, Rosa, Jacob, and others, and now Natalie within the education, we all work together, but they were our lead people in developing the material. Next one. And then we started also doing the health insurance one-on-one virtual classes. And then these were virtual classes for community members that attended. And some of the outcomes of those surveys, 100% agreed that they had a better understanding of health insurance and immigration topics related to insurance. 90% agreed that they have a better understanding of why it's important to have health insurance coverage. And then 80% agreed that they feel more confident in their ability to make informed decisions about health insurance. Next one. We also did the train the trainer modules, and that one where we had first trained 68 community health workers in the initial team,
81.
and then we invited 61,
81.
and then we 81. Sorry, I have another group of that we also trained through Will City Strongs, and I get those two numbers confused. So, and then we did a trainer where we invited community health workers from the FIEL-NC community health worker training program to then develop as trainers of future groups. And then we did virtual classes, 2-hour sessions with content, and then sessions to have them do the present the different ideas to others, with content review and homework. And they also, and then we have a picture coming up next. Can you put it, Paulina? Where we see them teaching in person the classes at the different branches of the Latino Community Credit Union. And then again, the in-person health insurance, what we call the Health Insurance 101 classes, they all agreed that they have a better understanding of why it was important. They felt more confident in their ability to make informed decisions about insurance. And then about 75% of uninsured participants were likely or very likely to enroll in health insurance after the class. And I don't think we have that written in here, but some of the conversations that we had later on with community health workers said that some people went to the class knowing that they may not be eligible, but it was important for them to be able to guide others in their eligibility. Participants share some of the comments here. They were grateful that they were teaching the class. They felt that it was important to share this type of information more often. Next one. And now we're going back to Gabriela about what are the outcomes and some of the publications.
I'll be brief because I think most important is talking about what we're doing now. But we have some publications that show kind of the basis for where this idea came from, that analyze the meeting minutes from Latin 19 to show barriers and solutions that came up during the pandemic to accessing health for Latino populations. We also did a focus group of community-based organization leaders and community health workers to understand some lessons learned during the pandemic. And then the last publication, we applied the level of racism framework, which is a framework used in research predominantly to describe, racism in Black and white populations. But in our situation, we wanted to see, do those definitions of racism and types of racism also apply to the experiences of Latino populations? And the answer was yes. So based on those findings and that research, we created a set of community-informed anti-racist policy recommendations that specifically address some of the forms of racism that are experienced by the Latino community, including increasing funding and support for community-based events in trusted community locations with Spanish-speaking providers and co-led by trusted CDOs, community outreach and engagement through community health workers, creating sustainable funding mechanisms to support community-based organizations, community health workers, and coalitions, and increasing alignment in language utilized by healthcare providers, researchers, and community members to improve the way we report data, collect data, and describe what is happening in our community. So talking more about what we're doing next, we have a lot of upcoming publications describing the work that we've talked to you about, and we can skip to the next slide and I'll tell you about our existing focus groups. So what we're focusing on now is related to what Anne asked in the chat. We want to know more about what people's experience has been trying to enroll in Medicaid during Medicaid expansion specifically. And, outside of Medicaid expansion, just what have been the experiences of people who either thought about enrolling but didn't enroll, thought about enrolling and tried to enroll, but maybe, weren't able to get through the process. actually were successful enrolling, you know, what helped them get enrolled and not be afraid of enrolling. And then and then for the population that, you know, tried to enroll and was rejected, you know, what happened? What was the problem? Because we know that often, and especially during redetermination process with PHE unwinding and all of that, a lot of people were rejected or unable to re-enroll because of missing paperwork. They didn't have the right documentation, they couldn't find certain documents, et cetera, or, you know, errors within the process. And so we want to make sure that the people who are eligible are actually able to get insurance, and that there aren't other barriers that we don't know about or that we could potentially address that exist out there. And so in the next slide, these are the flyers. And in this slide, you'll see that we have focus groups and surveys talking about these or asking these questions of both community members directly and community health workers. We know that our community health workers are central to our community and know so much about what's going on in our community. So we want to hear from community health workers about their experience helping people with this process and thinking about it. But we also want to hear from community members directly. What are their fears if they didn't attempt it at all? And how can we help address some of those fears and some of the barriers that they're actually experiencing? Or if it went well, what helped the process go well? So please share these links if you can. Share our flyers. We're happy to post it after the presentation, and help us get this out there so that we can make this a better process for people who are eligible, and continue to work on it.
Thanks, Gabby. And I'll just share one other upcoming portion of our work that we're doing. We have a presentation for community health workers, and we are inviting NCDHHS to present to this group of community health workers about understanding your rights